Hello, my name is Apurva V, and I'm the Associate Chief of Cardiology for Education and Program Director for the Cardiovascular Disease Fellowship at Lehigh Valley Heart Institute and Lehigh Valley Health Network in Allentown, Pennsylvania. Welcome to CVI Heartbites. CVI Heartbites is a free, non-accredited educational program produced by the Cardiovascular Institute of Philadelphia, featuring succinct presentations delivered by leading experts on timely topics in cardiovascular medicine. This CVI Heartbite segment focuses on the clinical implications of biomarkers in COVID-19. Please note, this presentation was recorded on May 7th, 2020, and the information was up to date at the time of this recording. At the end of my presentation, you will see additional resources and references and have the opportunity to contact me with any questions you may have. We'll start with providing some background on coronaviruses. In the 1960s, two seasonal human coronaviruses were discovered, the ET29-CoV and the OC43-CoV. More recently, in the late 90s, the other two coronaviruses listed there were also discovered and have been known to be globally endemic. These seasonal human coronaviruses are responsible for the common colds and relatively mild respiratory symptoms that we see, usually only resulting in upper respiratory tract infections. As a father of a recently turned 3-year-old, I was interested to know that 75% of children with antibodies to at least one of these four by the time that they're 4 years old. Also, there is some cross immunity, meaning that antibodies to one of these seasonal human coronaviruses can result in immunity to the other three. In contrast, the novel coronaviruses that are the topic of conversation today are primarily transmitted through zoonotic carriers and have resulted in significant global outbreaks. The first of these global outbreaks was SARS-CoV or coronavirus, discovered in 2002. The Middle Eastern Respiratory Syndrome coronavirus, discovered in 2012. And the severe acute respiratory syndrome, SARS-CoV-2, discovered last year in 2019. Obviously, these novel coronaviruses have resulted in global outbreaks and more recently a global pandemic. On the right panel, as Dr. Fauci has often mentioned, the SARS coronavirus 2 is very efficient at being able to infect a lot of people in a very short amount of time. When we compare the novel coronaviruses and their velocity, for the first 1,000 people to be infected, the MERS virus took approximately 900 days. The SARS-CoV-1 virus took approximately 130 days, and the SARS-CoV-2 has taken approximately a month and a half. So certainly a very significant velocity. When we look at this in another perspective, we see that the R0, which is the marker for how an individual who is infected can infect others, the COVID-19 disease has had a R0 of 2 to 2.5 people. As we consider opening up our doors and opening up our businesses and other avenues for entertainment, obviously this is something that has gotten a lot of press lately, but it's important to note that we have had over 3.7 million infections worldwide and 265,000 deaths, approximately 30% of these occurring in the United States, which is significantly higher than the SARS-CoV-1 and the MERS coronavirus. One of the things that's been an interesting observation and has been the subject of numerous literature has been the fact that the SARS-CoV-2 virus is more than just a respiratory virus. We know that there are patients, and the majority of them, who suffer from mild infections, but also a certain proportion of people who develop these severe infectious syndromes, which sometimes lead to significant morbidity and mortality. And this has continued to be a work in progress. We know that the virus binds to the ACE2 receptor in the lung epithelial cells, and that is how the virus enters into the lungs. We know that there is a macrophage response that then presents these to our innate and adaptive immunity mechanisms. But in some patients, the infection becomes more severe, and we'll talk about that later on. As we've begun to discover how this virus spreads and the severity with which it spreads, the CDC and the WHO have expanded the symptoms to look out for when we're considering COVID-19 as a possible etiology for a patient's presentation and symptoms. So obviously, as part of this diagnostic mechanism, one of the things that we often check are labs. And the role of biomarkers in COVID-19 has been the subject of a multitude of literature. And I hope to break it down in these three formats. One is the diagnostic utility. Can we use biomarkers to figure out which patients we're going to test for COVID-19 when they may have seemingly nonspecific symptoms? More importantly, who should we retest based on their clinical course? The prognostic utility of these biomarkers. Can we risk stratify or predict severe cases based on the results of these biomarker testing? And the therapeutic utility. Can biomarkers help or clue us into how to take care of these patients, often who are very sick? In terms of the diagnostic utility, context is key. Obviously, a high degree of clinical suspicion, along with the laboratory data and in supportive imaging, have been implicated in making a diagnosis of COVID-19. Some of the laboratory parameters can be seen here, and lymphopenia early on has been a very specific biomarker in patients with COVID-19 infection. In correlation with some of these other biomarkers, some of them are nonspecific inflammatory mediators, as well as organ-specific markers of tissue injury. That may help us clue in to whether or not the virus has bacterial superinfection or has involved other organ systems outside of the lungs. Nasopharyngeal swabs to obtain the sample for diagnosis of COVID-19 have been sort of the standard diagnostic method using reverse transcriptase PCR. Obviously, various companies have come out with ways in which we can do these nasopharyngeal swabs, and there's a very interesting video in the New England Journal of Medicine going through how to obtain a nasopharyngeal swab properly. However, given the rush to produce these diagnostic tests, it's also raised the question of whether or not these tests have a reasonable negative predictive value. In general, the current data shows that this negative predictive value is about 70 to 80%, meaning that there may be a chance that 20 to 30% of the patients that are tested may test negative, but in fact have the disease. At this time, it's still very difficult to parse out whether or not they tested negative at that time and then developed the disease later on and therefore became positive, or in fact, this was a true false negative, because as can be seen in the right panel here, this is predominantly retrospective in case series, which notes false negative reverse transcriptase PCR in this diagnosis. However, given our clinical suspicion and the patient's disease course, it may become important to determine what the true diagnosis is. So here's a case from the Washington University of St. Louis, in which a female with her first pregnancy was in 33 weeks of gestation and presented to the OB unit with contractions, emesis, and cough for 2 days. She was noted to have fever, tachycardia, tachypnea, lymphopenia, and elevated liver enzymes. The fetal testing was reassuring and her cervix was closed. An initial chest x-ray demonstrated subsegmental atelectasis, no consolidations or other pathology. Blood cultures, respiratory viral panel, nasopharyngeal swab for SARS-CoV-2 PCR testing was sent. During her hospital course, there were 2 samples sent on day 3 and day 4, both of which subsequently came back negative. Worsening cardiopulmonary status developed in this patient, unfortunately, and she was subsequently intubated. A CT chest was performed, shown here, And as can be seen, there is diffuse ground glass opacities bilaterally, some interstitial edema, as well as bilateral consolidations that can be seen in multiple lung fields. A stark difference from the chest X-ray report from admission. She, at this time, had been intubated and a bronchoalveolar lavage was performed, and the PCR came back positive indeed for SARS-CoV-2. Fortunately, she was able to be extubated on day 11, and both mom and baby were stable in the hospital at the time of this publication. This is certainly an example of where utilizing repeat testing to determine if a patient has COVID-19 may be important and help make diagnostic as well as therapeutic decisions in the disease course of a specific patient. This chart may be familiar to many and shows that there's essentially three phases to disease severity in patients. First being the early infection stage, second being the pulmonary phase, and third being the hyperinflammation stage. While this may not be sequential, or the time that the patient presents to the hospital, it may be at a different stage than when they initially contracted the virus, obviously. It does have some significant clinical implications as to how we may consider treating them, as well as what sort of imaging and diagnostic biomarkers can be assessed at that time. Initially, the clinical signs are consistent with lymphopenia along with constitutional symptoms. Thereafter, abnormal chest imaging can develop, and subsequently, when the disease severity has become more significant, we can see elevations in inflammatory mediators, some of which I will be speaking about next. When we think about the prognostic utility, particularly as cardiologists, one of the things that we're very familiar with looking at are cardiac biomarkers. And these cardiac biomarkers tend to be troponins and also NT-proBNP. In this study by Guo et al., published in JAMA Cardiology, they looked at close to 200 patients and noted that patients, whether or not they had cardiovascular disease, if they had elevated troponins, their mortality and outcomes were significantly worse than those that had negative troponins in the presence or absence of cardiovascular disease. The mechanisms by which troponin elevation occurs, as well as by which COVID-19 affects the heart, have been detailed in prior Heartbites talks. I won't go into too many details there. But obviously, the stresses on the cardiovascular system can result in elevated troponins as a result of plaque instability and plaque rupture caused by inflammation and viral invasion, and result in type 1 true myocardial infarctions. However, the hypoxemia, as well as the infectious process and its sort of systemic response, can also result in a supply-demand mismatch, resulting in type 2 MIs. There's also thoughts about the cytokines directly impacting the myocardium and resulting in a picture of myocarditis and COVID-19 infection directly of the heart, all of which result in elevation of these biomarkers. Regardless of how this occurs, increase in the biomarker does result in increased mortality. When we correlate this with NT-proBNP, we see that trending these biomarkers after being checked can help us get an idea of what sort of disease course the patient may be on and determine the trajectory of how we can potentially predict their disease course and manage them accordingly. In this patient population, if we look at the panel here, troponin elevations were noted in both fatal as well as patients that were able to recover from COVID-19. However, the troponins as well as the NT-proBNP biomarkers showed gradual and significant elevation in those with fatality, as opposed to relatively steady biomarker elevations in those that were cured or discharged from the hospital after recovering from this infection. Some of the other things that have gotten press, particularly of late, have been biomarkers as it relates to hypercoagulable state in the setting of COVID-19. One of the observations in COVID-19 patients has been the tendency to develop thrombi. And on the rightmost panel, you can see electron microscopy evidence noted very early on in our discovery of COVID-19, showing microthrombi in the pulmonary vasculature. In the study by Zhu et al., colleagues from Shanghai looked at 303 patients that were hospitalized and 240 that were discharged, and noted that all of these patients had elevations in biomarkers suggestive of hypercoagulable states. But notably, fibrinogen and D dimers were significantly elevated in patients, particularly in patients with a severe disease course, and suggestive of the likelihood of developing a coagulopathic situation. While initially these D dimer elevations were noted in patients that had microthrombi, more recently there has also been an increase in observations of patients developing pulmonary embolus and venous thromboembolism. In this case series published in Circulation, colleagues from northern France reported an increase in patients with pulmonary embolism during a time between late February and March, and looked at this time period from this year in comparison to 2019, noted here in the leftmost panel. In the patients admitted to the ICU during that time, of those that had undergone CT scans, certainly the number of pulmonary embolism diagnosed was more prevalent in the 2020 group as opposed to the 2019. When looking at the year 2019 as a whole, particularly with patients with influenza that were PCR positive for flu, there's also an increase in the number of PE cases in COVID-19 patients as opposed to both flu and all comers as it relates to the ICU. This has certainly gotten a lot of lay press, especially of late, particularly because of it highlighting the fact that this is something which impacts younger patient populations that were initially determined to be of relatively low risk and having a mild clinical course. Oxley and colleagues from Mount Sinai published this case series in the New England Journal of Medicine recently, showing relatively young patients whose initial presentation was large vessel strokes, who had had prior symptoms that were relatively unremarkable, and all had tested positive for COVID-19. This has raised the question of whether or not there is an underlying hypercoagulability of particular or special to COVID-19 that may be resulting in these pulmonary thromboemboli as well as large vessel strokes in the brain. Interestingly, I will note that at least in this case series of only 5 patients, the fibrinogen and D dimer is relatively been nonspecific with some significant elevations in some and relatively benign values in others. And so it does raise the question that there needs to be a better understanding of the relationship between COVID-19 and coagulopathy. Based on the data available, the American Society of Hematology has put together the following therapeutic guidelines to determine who should be treated for venous thromboembolism, who should be prophylaxed, and who should be monitored. It's noted that coagulopathy is manifest as elevation of these biomarkers and platelet counts early in the stages of infection. Increasing levels of interleukin-6 are correlated with increasing fibrinogen levels. Elevated D dimer admission is associated with increased mortality, as we noted, and rising D dimer trends after admission can potentially portend multi-organ failure and overt DIC. Bleeding manifestations in these patients that do go on to develop DIC are actually relatively uncommon, and it seems as if clotting has been more frequent than bleeding. Based on these observations, all patients that are admitted to the hospital should have coagulation testing, particularly fibrinogen and D dimer. Those patients that are on the wards should undergo standard VTE prophylaxis. Those that are admitted to the ICUs and develop ARDS may benefit from escalated doses of VTE prophylaxis, which is essentially half the dose of a therapeutic dose of anticoagulation. And this is primarily based on observational studies and common practices across ICUs globally as well as in the United States. And therapeutic anticoagulation be reserved for patients with confirmed VTE or a high degree of suspicion for pulmonary embolism. In the outpatient realm, there is a recommendation to consider VTE prophylaxis in patients that may be considered at high risk of developing coagulopathic complications, particularly those that are bedbound or relatively sedentary populations, as well as those that are morbidly obese. And both of those risk factors could place them at a higher risk of developing embolic complications. The choice of anticoagulant, many have been trialed, and obviously unfractionated heparin, low molecular weight heparin, and fondaparinol seem to have the most data. However, DOACs have also been used. However, it's unclear what that intermediate dose of DOAC would be in treating some of these patients for escalated doses of VTE prophylaxis. The final area of prognostic utility is in this phenomenon of cytokine storm. While we continue to learn more and more about how COVID-19 impacts our inflammatory mediators and cytokines, one of the things that we've known or learned is that in patients with mild disease, macrophages pick up viral particles, present them to our T cells, and then our innate and adaptive immune systems quickly regulate and decrease the viral load of COVID-19 and lead to relatively mild symptoms and benign presentations where patients generally recover. However, in a certain proportion of patients, they develop severe disease and severe cases, and the immune response is considered to be defective. Cytokine pathways that have been implicated have all included interleukin-6, which has become an important biomarker in this. And this results in a profound release of pro-inflammatory cytokines, resulting in a breakdown of epithelial and endothelial barriers, resulting in ARDS in the lungs, significant pulmonary edema, as well as extension into the other organs, particularly the heart, the kidneys, and the lungs, and result in subsequent multi-organ failure. It's still unknown why this hyperresponse occurs in some patients and spares others. Obviously, elevations in interleukin-6 levels portend a higher likelihood of developing a more severe disease course, along with other inflammatory biomarkers such as CRP and ferritin. However, one area in which this is now being utilized is to track IL-6 in the bloodstream and trend IL-6 levels in order to say if patients that are at risk and in the severe category, can trending these biomarkers lead to a better prognosis if there's a downtrend versus an uptrend, which may predict a higher degree of death and mortality. Obviously, at the end of the day, we hope that some of these biomarkers and investigations ongoing will result in ways in which we can definitively treat our patients. At the time of putting these slides together, there were no currently effective therapies proven to cure or prevent COVID-19 infection. Research is obviously occurring at a rapid rate, and these include pharmacologic therapies, repurposing old antiretroviral agents that are effective for other viral pathologies and utilizing them in COVID-19 infection, as well as efforts towards vaccine development and other invasive interventions, such as filtering cytokines from the body in order to minimize the severity of a cytokine storm syndrome. Obviously, there needs to be a balance between safety and efficacy. And in this article in Circulation recently published, shows that certainly COVID-19 can impact the heart, as we previously mentioned, resulting in tachyarrhythmias through myocardial injury and direct myocardial invasion potentially, but also through antiviral therapies, which may result in prolonged QT, impact the ability of them to be metabolized properly in the liver parenchyma, and subsequently result in QTc prolongation, resulting in polymorphic VT and Prasad. So in summary, some of the biomarkers that have been implicated have been lymphocytopenia, and a lymphocyte count when trended has shown that a lower lymphocyte count is noted in non-survivors as compared to survivors. D-dimer elevations certainly have been noted in patients that have worse outcomes, along with interleukin-6, acute phase reactants such as serum ferritin, and cardiac troponin and lactate dehydrogenase. Biomarkers play a complementary role in the diagnostic evaluation of patients with COVID-19, certainly a high degree of clinical suspicion, and putting that into the bigger picture of imaging data as well as laboratory data may be important in determining who we should test and retest. Biomarkers also have prognostic value and may predict severity of disease, as outlined here. And biomarkers may signal potential targets for therapeutic investigations, and we keep our fingers crossed as we continue to care for patients with COVID-19 that we will be able to develop therapies for which we can definitively treat them. These are some references used in this presentation. I will also point out resources at Lehigh Valley Library Services, which have tabulated all of the recent articles and are kept up to date. And I encourage you to look at this resource for the most up-to-date information on the data surrounding COVID-19. If you have any questions for me, please email Mark Hartnett, the Executive Director, at cvi.markhartnett@verizon.net. Feel free to share this link with anyone who may be interested in this information, and please let us know if there are other topics that may be of interest to you. Thank you for watching the CVI Heartbites segment. For more information on CVI Heartbite segments, on other CVI Heartbite segments, as well as other CVI educational programs, please visit us at cviphiladelphia.org. Follow us on Twitter at CVI_Philadelphia or _Phila, #CVI Heartbites. Thank you.